Hi everyone, we're going to talk about Chapter 18, Psychosocial Problems. There's a lot of information. Some of it is better served by you reading it, so if I may direct you to particular sections of the chapter to read, but let's get started. Psychosocial and mental health problems make up approximately 22% of all visits that are seen in primary care. As we know, with more individuals having psychosocial issues and their difficulty in getting in to see psychiatrists, psychologists, counselors, etc., primary care is taking on more of that initial burden and getting management of those conditions started. Just to appreciate some of the numbers, the lifetime risk for a mental health disorder for individuals in the U.S. is approximately 50%, and approximately 1 in 4 Americans age 18 or older suffer from a diagnosable mental health issue. As well as the burden of illness, there is also, sorry for the interruption, there's a significant economic impact of treating these disorders, and over the last decade, the cost of treating mental health issues have gone from approximately $25 billion up to $60 billion, and they comprise one of the 5 most costly medical conditions. When you're dealing with psychosocial issues, making a diagnosis and based on certain criteria is important. There is the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition, the DSM-5, which provides user information, diagnostic criteria, offers a cultural component. It has categories that help you to make your diagnosis, but the DSM-5 coding is not consistent with the ICD-10 coding, so those two do not correlate. All right, let's talk about some few common complaints that you might see for psychosocial issues in primary practice. We're going to discuss anxiety, mood changes, insomnia, serious mental illnesses, and substance abuse. So some common complaints that your patient may voice to you could be related to anxiety, mood disorders, suicide, psychotic disorders, grief, intimate partner violence, substance abuse, sleep disorders, eating disorders, attention deficit, and sexual assault. And we are going to touch on all of these. Anxiety disorders impact approximately 40 million adults in the U.S., therefore making it the most common psychiatric disorder. It presents between 20 and 45 years old typically and affects women more often than it does men. Its symptoms can be seen in several different ways, whether they're being affective, cognitive, behavioral, or somatic. Affectively is when anxiety is that experience of dread or panic. You may see the patient have a primarily sympathetic response, such as increased activity. Your patient may show signs of apprehension, fear, irritability. They may be frustrated or overreact easily or become very hypersensitive. Some behavioral symptoms that they may exhibit could be apathy, compulsion, preoccupation, repetitive actions. And some somatic symptoms could be loss of appetite, dry mouth, fatigue, GI issues, nausea, vomiting, diarrhea. And your patients may have a combination of all of these type of symptoms, or maybe just a few. In your book on table 18.1, there is a good chart on the classification of anxiety disorders, and I encourage you to look at that as it breaks it down with some commonly associated symptoms. The first one we're going to talk about is your generalized anxiety disorder. And it's characterized by excessive worry that can last over 6 months with multiple concerns and difficult to control. Generalized anxiety disorder can be more disruptive to the patient's normal day-to-day activities and above what their normal anxiety can be. Approximately 50 to 90% of patients that have generalized anxiety disorders have another comorbid mental disorder, most commonly depression. There is evidence to show that there is a genetic component that can contribute to the development of anxiety disorders. So it's important to assess your patient to see if there are other family members that have anxiety issues. It is also known that individuals that have anxiety disorders have a increased sympathetic tone, so that they are slow to respond to repeated stimuli, and they can also respond excessively to moderate stimuli. The three major neurotransmitters associated with anxiety are norepinephrine, serotonin, and GABA. In the book, page 1030, Advanced Assessment 18.2, there is a excellent screening and diagnostic tool that you might consider incorporating into your practice that may help with diagnosis of individuals that have anxiety disorders. When you're attempting to take care of these patients, education is in the foundation of your beginning interventions. The patient needs as much information as you can provide on the condition so that they can understand it. They need to be aware of symptom recognition, ways to interpret their physical symptoms, ways to decrease stimulation, such as avoiding alcohol and other stimulants, including nicotine. They need information on relaxation training as well. Those that have a generalized anxiety disorder, those that develop routine methods of helping to deal with anxiety and to promote relaxation, are more successful at managing their condition than those individuals that just implement those techniques on an as-needed basis. On page 1032, there is drugs commonly prescribed for anti-anxiety agents. Benzos can be very helpful in the management of generalized anxiety disorder, but many of these patients also have a comorbid diagnosis of depression, and so benzos can often then exacerbate the depression if they are on a benzodiazepine. And then, of course, we run the risk with dependents being on these medications for long-term use. So a better choice for long-term use for anxiety may be your SSRIs, such as your Lexapro, your Paxil, your Zoloft. Be sure and review all those different classes of medicines in that chart. We talked a little bit about this briefly, but for non-pharmacological interventions, relaxation skills, also cognitive behavioral therapy, and you can find more about that on table 18.3 on page 1033 in the book. Also, good nutrition is very helpful. For follow-up, you would initially start with a monthly follow-up to see and assess how their symptoms are, and to assess the severity of the anxiety on treatment and look for improvements. And you're also wanting to assess for any suicidal or homicidal risk. Next, we're going to talk a little bit about panic disorders. It typically presents in young adulthood and can be disabling. For those individuals that suffer from this, it can impact their social, family, and working lives. The symptoms are recurrent, intense. They have short episodes of panic level, psychological, and physical symptoms. It's important to know the difference between panic disorders and panic attacks. And the main distinction based on the DSM-5 is that the diagnosis of a panic disorder is based on a pattern of recurrent, unexpected panic attacks, and at least one of these attacks must have been followed by 1 month or more of persistent worry and/or maladaptive changes in behavior. Clinically, you're wanting to assess for a pattern of recurrent episodes. You're looking for sudden onset, severe symptoms. Panic disorders can be associated with medical problems, and they may be associated with or without agoraphobia. Let's talk a little bit about the patho and the epidemiology associated with panic disorders. They're twice as frequent in women than men, typically peaks at age 25, and then again between 35 and 44 years old. They can be genetic. They impact both the peripheral and the central nervous system. When an individual is having a panic attack, MRIs have shown that there's an increased involvement in the temporal lobes, especially the hippocampus. It's important also to rule out other diagnoses as you are making your determinations. You need to make sure there are not medical issues that are going on. Could what is going on be related to a medication such as theophylline, steroids? Could there be recreational drug use? And also, are there any other comorbid psychiatric disorders going on? In your workup of the patient, you're going to check chemistries, an ECG, thyroid function. You're going to educate your patient on understanding the disorder, how it's impacting them, the causes of it, relaxation skills. Medication management may include SSRIs, cognitive behavioral therapy and relaxation, good nutrition, and follow-up will be in 1 to 2 weeks initially, and then follow-up will be based on the severity of the condition and the safety risk. Let's talk next about post-traumatic stress disorder, which is a syndrome that can develop after a individual witnesses, participates in, or hears an extreme traumatic stressor. The reaction is typically fear and helplessness, and they feel like they're reliving the event over and over. The symptoms must be severe enough to last greater than 1 month after the event. The symptoms are typically responses to experiences that have been overwhelming for the individual, such as war, torture, disasters, terrorism, assault, rape, serious accidents, fires, etc. There are different types of PTSD: acute, which is less than 3 months, chronic greater than 3 months, and delayed has an onset of at least 6 months after the trauma. So in the general population, approximately 8 to 9% can be affected by PTSD, and is twice as common in women, often seen as a result of a rape or a sexual assault. For men, it's most commonly associated with military combat or witnessing a form of extreme violence. The response to the PTSD is thought to be a noradrenergic system malfunction. The individual may experience nervousness, high blood pressure, increased heart rates, sweating, flushing, tremors. Studies have also shown that there can be a cortisol hypersuppression in trauma-exposed patients compared to patients exposed to trauma who did not develop PTSD. Other diagnoses to consider in your workup would be anxiety, substance abuse, mood disorders, and other comorbid psychiatric disorders. It's important with these patients to educate them on the chronic nature of the condition. Pharmacology-wise, your SSRIs are very beneficial. Non-pharmacological-wise, having a debriefing may help, especially an individual in this war situation or some type of fighting situation. They can benefit from cognitive behavioral therapy and prolonged exposure to help them become more acclimated or comfortable with the trigger for their PTSD. All of this would be done under the assistance of a behavioral specialist. Their other interventions could include stress inoculation therapy, image rehearsal therapy, psychodynamic therapy, and family, group, and peer therapy. Let's talk a little bit about OCD, which can include both obsessions or compulsions. The patient can have increased distress, and even though they realize that something may be unreasonable, they're unable to make a change. It has an earlier onset in men and a later onset in women. It can be chronic. It can have a genetic component, and first-degree relatives with OCD and Tourette syndrome can have a correlation. There is a commonality between OCD and depressive disorders, and studies have shown that the similarities are seen in sleep, EEG studies, and in neuroendocrine dexamethasone testing. Some differential diagnoses to also include would be Group A beta hemolytic strep, pregnancy, postpartum depression, eating disorders, mood disorders, ADHD, Tourette's, or a temporal lobe epilepsy. First line to help with OCDs are your SSRIs. Second line is clomipramine, which is also known as anafranil. tricyclic that can be used as second-line therapy. However, it has risk of seizures, weight gains, and cardiovascular events, and so those need to be closely monitored. As we've discussed earlier, CBT is very important. You may use exposure with response prevention as part of management of this. There are self-rating scales out that the patient may be able to use to assess the level of their tendencies. And then two specific rate severity scales are the Yales-Brown OC scale, and then there's a children's version. Education of the disorder is very important in encouraging treatment compliance and medication follow-up. Also, follow-up will be based on the severity ratings of the condition. You may want to see them weekly for a month and then refer to a behavioral specialist. Our next category that we're going to talk about are disorders that may include depressive symptomatology. These could include major depressive disorders, persistent depressive disorders, postpartum depression, and bipolar and related disorders. So depression is something that's very common in primary care settings, and it is something that you need to determine what the patient's definition of depression is in comparison to yours, because it can be used for a wide variety of negative emotional experiences that could range from sadness to disinterest in pleasurable activities to include self-hate. But the classic hallmark symptoms of major depression are sadness and apathy. There are several tools that are available that will help you to screen for the depression. You may use any of these in practice, may see these in practice. PHQ-9 is very popular, but there's also the Quick Inventory of Depressive Symptomatology, the Zung Self-Rating Depression Scale, the Beck Depression Inventory, and Geriatric Depression Scale. When you're going to make your diagnosis for depression, the patient needs to have 5 or more of the DSM-5 criteria symptoms for 2 weeks, with at least either a depressed mood or a loss of interest or pleasure in life activities. A quick screening may include asking if they've felt down or helpless over the past month, little interest in doing things that have brought pleasure in the past. It's important to assess for any danger signs and symptoms, such as hallucinations, delusions, suicidal tendencies, homicidal tendencies, extreme self-care deficits, or adverse effects after medications prescribed. In your education, it's important to give them as much teaching information as you can on the medications, what to do if they are in an emergency and they feel that they may harm themselves, and then also give them a written emergency plan. A list of medications can be found on page 1052 in table 18.2. We are not going to go into each of them specifically, but it's broken down by the drug, the reason for it, and any adverse reactions and prescribing considerations. So I encourage you to review that. It includes both SSRIs, SNRIs, tricyclics, serotonin modulators, and several other categories. As we've talked about in other conditions, non-pharmacological can include CBT, interpersonal therapy, medication combinations. It's important to utilize family, friends, and other supports that the individual may have. Follow-up will be dependent on danger signs and symptoms, and then it's important to continue to assess using formal diagnostic tools. With bipolar disorders, it's often mistaken for a major depressive disorder. It's a recurrent mood disorder that you can have 1 or more episodes of mania, hypermania, or mixed. There is bipolar 1, which has at least 1 episode of true mania preceded or followed by a hypomanic or a major depressive episode. Bipolar 2, which is characterized by a recurrent depression and hypomania. And then cyclothymia involves symptoms of hypomania and depression that do not meet the full criteria for either of the other disorders. The pathogenesis of bipolar disorders is not clear, but it is felt that biological, psychological, and social factors are thought to contribute to it. It's the sixth leading cause of a disability worldwide in patients aged 15 to 55. 25% to 50% of patients with bipolar disorders have a lifetime risk of suicide attempt, and up to 15% of patients complete the attempt. On page 1058 on table 18.6, there's some definitions for symptom criteria for the different levels of bipolar disease. I encourage you to read those. We reviewed a little bit of this, but men and women are equal in the incidence of bipolar disease. Bipolar 2 is higher in men. It is rare that it occurs after the age of 40. There is a genetic component where if one parent had it, you have a 50% chance of getting. If both parents, that increases to 50 to 75%. Approximately 69% of individuals are misdiagnosed, and there is a high comorbid substance abuse associated with bipolar disease. And then also 50 to 80% can have other psychotic symptoms. So in the office, best way to understand what the patient may be going through, an acronym to help with that may be DIGFAST. The patient may show that they are distracted easily. They may have insomnia. They may have grandiosity, flight of ideas, lots of activities, speech, thoughtlessness. If your patient has three of the mentioned ones in the DIGFAST criteria, that can be labeled as euphoria. 4 of the ones listed, and they can fall under the irritability category. In assessment of these patients, from a lab perspective, you may order a CBC, blood chemistries, thyroid studies, RPR, HIV, urine toxicologies, and a pregnancy test. With patients that suffer from bipolar disorders, your goal is to help them achieve complete remission of current symptoms and to prevent future affective episodes and to return to pre-morbid functions. The medications that help to achieve these are your mood stabilizers. Other medications are anticonvulsants and maybe combinations of medicines. On page 1064, table 18.8, are medications that are used for the management of bipolar disorder. Factors that will determine which medication to choose will be dependent on the diagnosis. And as with most conditions, it's very important to use the lowest possible dose to minimize side effects, especially with first-generation agents. It's important with these patients to have good understanding and education of the condition, because there may be denial of the diagnosis. Many of these individuals may not be willing to take medicines as they should, especially if they are in a more of a manic phase. It's important to set up realistic goals, look for signs of destabilization that may present early, and do lab values when appropriate. These folks need to limit their stimulants and need to practice good health measures to include routine schedules and good sleep habits. These patients may benefit from talking to a psychiatrist, cognitive behavioral therapy, supportive therapies, and then if there is concerns for danger to themselves or others, an involuntary hospitalization may be needed. Follow-up will include monitoring for medication blood levels, adherence to medications, assessing for suicide and homicidal risk, and then assessing for how well they're functioning, self-care, psychosis, substance uses. I think we're at a good point that we'll end this video, and we'll come back to talk about suicide.